I am Dr. Kimberly Jones. I'm the CF Center Director. And a couple of really good friends approached me in the parking lot one night and they said, hey, would you come give us a talk on CF exacerbations? Well, I was running between clinic and somewhere else and I was like, yeah, that'd be fine. And I get in my car and I drive off and I go, really? You just agreed to give a talk on something that can't be defined? Really? So I kind of took a little twist on this so that we can make a little bit of sense. But specifically, I wanted to start with why are we even doing and talking about care of adults. So in 1970, only about 10% of our patients would even have been considered an adult. And obviously statistics show that we are getting better and better with this. By 2013, which is really our most recent center data, almost 50% of our population is now over the age of 18. So we're now looking at expanding numbers, and we're saying a median age really of somewhere around 40.7. So that means that half of our patients are even living longer than this. So in the late 1990s, there was this push to say, we need adult care for adults. We need to have physicians who are trained in adult care caring for these patients. So when I joined the faculty in 2000 is when we started the adult program here. And just a few years after that, we were up to 80 adult programs, and now in 2013, we're looking at 96 adult programs currently in the U.S. So obviously there was a need, and that need is being met. So this is our most recent data straight out of the registry, and you're going to see a whole bunch of charts like this that I graciously stole and copied. But you can see, so in the mid-80s, only about a third, not even a third of our patients were over the age of 18. But as the 2013 data shows, we're really almost evenly split. So the need is there. And the healthcare needs are huge because this is obviously going to be our sicker population. They're older, they're going to be sicker. And on average, we are expecting our patients to make quarterly visits. On average, they have slightly more than that because of sick visits or what have you, but we're expecting them to come every 3 months for follow-up. Our data shows that they have about 1.5 acute exacerbations per year and about 1 hospitalization per year per patient. So there's a huge healthcare burden in caring for these patients as well. Okay, so if I can find the pointer, I will try and make this make sense. Ooh, I have no idea what I did. Okay, maybe I won't use a pointer. Maybe I'll just use this. Okay, so you can see that under 18, we're only looking at about 25% or less exacerbations per year. But over the age of 18, about, on average, half of our patients are going to have an exacerbation. Total duration of IV antibiotic therapy under the age of 18. So we're looking at about 14 days. Over the age of 18, same thing. Median, about 14 days of IV antibiotics. So that means for every exacerbation, they're missing 2 weeks of their life. Now, they don't necessarily have to remain in the hospital for that entire 14 days. It may be that, you know, they're only in for a week and they're out for a week. But you can see the range of how much time they're spending in the hospital. So at least once a year, we're taking them out of whatever they're doing, we're sticking them in the hospital, and we're doing IV antibiotics on them. Huge life disruption, on top of the fact that we've also asked them to come to clinic 4 other times during the year and miss work, school, what have you. Okay, well, so that's what we ask. But actually, our statistics show that if they're 18 and older, only about half of the patients really make all 4 of those clinic visits. We are expected as an accredited center to document how many of our patients are coming for quarterly visits, how many of our patients are getting what is now recommended quarterly cultures, and at least twice a year pulmonary function test. Our kids do great with this. In the pediatric population, moms are missing work and they're getting the kids there, and kids are missing school, but I mean, we overall do pretty well with this. But you can see in our adults, maybe not so great, and you can certainly see the range here. Getting cultures, about half. Getting PFTs, this occurs, but keep in mind that when they're in the hospital, we're also getting PFTs. So that may be what we're seeing reflected there. And our socioeconomic characteristics are pretty interesting for this patient population. So back when I first started in CF care, patients really weren't expected to live into adulthood. So patients weren't really encouraged to have a career. They weren't really encouraged to go to college, to secure insurance for that matter. But you can see in today's world now, they're not only graduating high school, but they're attending college. We've got some even getting master's or doctorate level degrees. If you look at the far right in employment, almost 3/4 are either employed full-time, part-time, or they're a student. So they're actually living and they're thriving. Now, look at this one here. We're seeing that over half of our patients are single. So now we've got the demands of we're going to work full-time or we're going to be a full-time student, ever how they want to play that, but they've got demands on their life, plus they got to miss time for clinic visits, not to mention if they have other specialists following them. Plus I just took 2 weeks of their time for IV antibiotics. Most people only get 2 weeks of vacation per year, and somehow you've got to play that 2 weeks to make it work for you. So when you see my grumpy adults in the hospital, please be a little tolerant of their grumpiness, because they got a whole lot on their plate that they're juggling, not to mention co-pays and everything else. Okay, so our current center has about 150 patients, and we're pretty evenly split and have been for probably the last 6, 7, 8 years, about half pediatric and half adult. We keep track of our admissions, so that's where I'm getting this from. But we average about 2 pediatric admissions a month and about 4.5 adult admissions per month, but you can see the range. Sometimes we have really stinky months. Our average length of stay ranges anywhere from 1 to 2 weeks. So very in line with the data that you just saw that's occurring across the country. Okay, so I wanted to hit some highlights specific to adult care. This document came out in 2004. Lead author was Jim Yankaskis, who's at UNC in Chapel Hill. And really what they were trying to do was to standardize care for these adult patients and set down some guidelines that we can sort of follow. Now I said that this is obviously going to be our sicker population. So they're also going to have a whole lot more comorbidities going along with that. And that's really what this document focused on. Okay, so their recommendations are that adult CF patients receive, first of all, multidiscipline care. And they recommended at least a part-time commitment from some physician who's been trained in medicine, a nurse, an RT, a dietitian, and a social worker. We meet their minimum criteria. Other centers have multiple physicians. They have multiple nurses and RTs, and they have PT, and they have psychology, and they have GI attending their clinics. Some of these clinics are huge. We're meeting the minimum. And what they expect of us is this. And really, I highlighted and I bolded this so that you guys can understand our role is simply to coordinate their care. Obviously, we want them to have the best possible care. We want to make sure that they have access to the resources they need. But our role as a CF team is to coordinate that care between the primary care and other specialists. We are not trying to be a primary care at all. I got enough on my plate, thank you very much. And that was clearly highlighted in the document. This is what they are expecting us to do. Let me also say that the other thing they're expecting us to do is to get you guys involved in CF care. Every 5 years they come around and reaccredit us. And we're up for that sometime in the very near future. And they look to see what's going on in clinic, who's seeing them, are there adult providers actually seeing these patients in clinic? When they're hospitalized, where are they going? Are they going to a pediatric floor? Are they going to an adult floor? Are they being cared for by adult providers? And so that's why y'all have seen increasingly our adults pushed toward y'all, because we're supposed to. And quite honestly, the pediatricians don't want to care for a 54-year-old lady. They just don't like that. Makes good sense to me. Okay. So I wanted to highlight the complications so that y'all can kind of see, first of all, what we're dealing with, how complex this disease can be, and secondly, because you guys are very good at guideline care, and that's what the internist does, is well care. And there's several things in these complications in which y'all probably would pick up even faster than we would with everything else that we're juggling. So CF-related diabetes. Okay, so yes, this is occurring in a greater frequency in our adults. But why do we have to tag on CF-related? Why does that even matter? Well, it matters because it's a unique entity in and of itself. If we miss it, if we don't diagnose it, if we don't take care of it, we see that their mortality rapidly increases. And that's, in fact, one of the things that prompts us to screen for it, is seeing declining weight and declining lung functions. Obviously, risk factors, if they become pregnant, and yes, that is something else we get to contend with every now and then, if they become pregnant and they develop diabetes, then the data shows us that their mortality rapidly increases. Their PFTs rapidly decline. So even for the obstetrician, there's another obstacle, even with a pregnant CF patient. But pregnancy is a risk factor. Steroid use, which I try at all costs to avoid in these patients, but sometimes you do what you gotta do. And then of course our post-transplant patients, I would say probably 95 to 100% of our post-transplant patients are diabetic, just across the board. But it's not a type 1, and it's not really a type 2 either. So we don't use oral agents, first of all, because they really don't respond to them. Unlike a type 1, they're still making some insulin. So we don't, I don't want to say never, because God knows the next person rolling in could do it, but we almost never see DKA in these patients. They just don't do that. And many times we're labeling a diabetic with a normal fasting glucose. So they're not a true type 1. And here's the other difference. We treat them differently. If we start putting them on 2,000 calorie ADA diets, these patients aren't going to thrive. They're going to start losing weight like crazy. Because remember, they've got fat problems as far as digestion. Well, where's most of your calories coming from? Your carbs and your fat, right? So we're already having issues on one end. If we start limiting their dietary intake and cutting calories, they're going to lose weight every single time. So our only dietary modification is don't eat just your Skittles. Don't drink regular sodas. No concentrated sweets. But beyond that, you want that piece of cake? Great, eat that piece of cake, but eat it with a meal. Put it with a protein source. So we're still saying high calorie, high protein meals. We're still doing snacks 2 to 3 times a day. We're still pushing calories at them. We modify the insulin to meet what they're going to eat. And the most controlled patients we have actually do well with a pump and with carb counting. Not every patient can carb count. It's just the way it is. Some of them, you can give them the app and they still can't carb count. But for those that can, those are the ones who are the most controlled. We really don't see the macrovascular complications of diabetes either, but we do see the microvascular. So many of these patients have renal issues, and that's not surprising. They're in the hospital, we hit them with tons of hardcore antibiotics that, you know, the aminoglycosides, the vancomycin, we're already pummeling their kidneys. And then we get diabetes on top of that. So we definitely see that, and we screen for it. So we recommend that these guys see an endocrinologist. That's the greatest. And endocrinology here has done phenomenal. Like, they get CF diabetes, so when they're in the hospital and you have a question, ask them, because they totally get it. But if they don't, we in a clinic try to follow quarterly A1Cs. We ask them, have you had your annual eye exam? We do a yearly microalbumin. We try to follow it, but we are not endocrinologists. We are just a good old pulmonary doc who's trying to do it all, I guess. So we do encourage them to get an endocrinologist, and many that do wind up with that insulin pump doing much better than I could have ever done. Okay, so that's one complication we see. Cancer risk, shockingly. But even though it's still low, it's higher than the general population, and particularly colon cancer. And that's not really all that shocking when you look at other chronic disorders that affect the GI tract, and you see increased malignancy in that population as well. The current recommendation is for those patients over 40 to have yearly colonoscopies. Okay, well, you see what I have right after that. So if you look at some of the big centers who are actually trying to get this accomplished, when I say rigorous, I'm talking like a 3-day prep. Now, how many people are going to want to take an additional 3 days out of their life when I've already told you, quarterly visits, 2 weeks a year, oh wait, I just lost all my vacation time for the year, 3 more days so that I can go get a colonoscopy. Okay, so we haven't pushed this one yet, but it makes sense because the same thick, sticky mucus that's in the lungs, that's in the sinuses, lines that GI tract. So it's very hard to completely clean out a CF patient. That protocol is online. You can find it as to what other centers are doing. Right now, we're picking our battles, and this is not a battle, at least not yet. But it probably should be. Let me just say that. Okay, anxiety and depression. I said that some centers actually have psychologists, psychiatrists that attend their clinics, and it would be lovely if we did, because God knows we need it. But we screen for that, and actually our social worker has taken this on just in the last quarter as something that he really wants us to focus on. He's pulled out an anxiety questionnaire, a depression questionnaire, and when he goes in and does his annual assessment, he is doing these questionnaires with the families, and if he is identifying a problem, then he's coming back to us and saying, hey, we got an issue here. But you can see the incidence that's listed out of the 30,000 patients that are in the registry. So you could pretty much in any given clinic just go, probably that one, and you'd probably be right. But we're trying to do it, obviously, in a very strategic way so that we're not wasting resources that are so precious. So once we figure this out, what are we going to do with it? Again, I'm a pulmonologist. I'm not a psychiatrist. What are we going to do with all this anxiety and depression? We usually will attempt at least 1 or 2 tries, and then I'm trying to find resources for them in the community. That is one thing our social workers lined up. Where are counseling services available for these adult patients so that we can at least get that going? And then osteoporosis. So this occurs for a multifactorial reason, but we're seeing this even in our very young adults, in our 20, 21-year-olds, we're seeing osteoporosis. Their metabolism is very different. So they've got decreased osteoblastic activity. They've got increased osteoclastic activity. So we're breaking that bone down rapidly anyway. We're pretty sure the fact that they have fat-soluble vitamin malabsorption and hence low vitamin D is also contributing to this osteoporosis. And our current recommendation is for baseline DEXA screening at age 18, unless we're seeing something sooner, like somebody's got a really low BMI, really low FEV1, they've been on steroids for a prolonged period of time, you know, other normal risk factors, then of course we would screen earlier. But this is our recommendation. So again, I'm asking them to take a half day to go get a DEXA scan on top of the other things that we're putting on their plate. If it's normal, then we're rescreening about every 2 to 4 years, depending upon how easily this is accomplished for that patient. And then if abnormal, then we're looking at risk factors. We're trying to treat other variables, but many of these patients are on medications for it as well. So, and optimizing vitamin D in these patients has been a huge challenge for us, for them to absorb enough, first of all, and for them to actually get out and get the sunlight so it works. Huge challenge. Maybe not as challenging as Wisconsin, but challenging enough. Okay, so you can see that all of these complications increase in frequency as they approach adulthood. So you guys, y'all are going to be seeing these in these patients. The thing that I didn't talk about is arthritis and arthropathy, and if there's rheumatology in the room, then maybe y'all could speak to it afterwards. But I don't have a great understanding of the CF arthritis and arthropathy, and it tends to be more of an arthropathy. There's not redness, there's not swelling. They just hurt. They just hurt. What do you do with that? All right, so here was my dilemma. How do I define an exacerbation? And this is, let me just say, everyone's dilemma. So if you talk to a CF provider, they're going to tell you, oh, well, you just know when it's an exacerbation. When they've got increased cough, when they've got increased sputum, when they've got decreased PFTs, when they've got other subjective symptoms like weight loss, fatigue, decreased appetite, all of that is an exacerbation. But not every patient has all of this. So is it not an exacerbation if you don't have all of that? What do you then call it? So nobody has really standardized what's an exacerbation. And it's going to look different depending on the patient. So if I've got an FEV1 normally of 120%, but now my FEV1 is 90, is that not an exacerbation? Well, it probably is. If I've got the other signs and symptoms to go along with it and I've been doing what I was supposed to do at home. Not all of them are admission worthy. So who do we treat outpatient? Who do we treat inpatient? Is there any kind of standardization that's going on in our clinic? Well, we've tried. So in 2001, they first attempted, let's define it. So they had a phase 3 trial going on. They were looking at one of the inhaled antibiotics, and they were looking at AEs and SAEs. And they said, what are people calling an exacerbation? What criteria are they using to define this? And so you can see what the odds ratio were. If they had increased cough, if they had increased sputum, it was probably an exacerbation. The other things, as you go down, certainly had less likelihood of being called that. And interestingly, physical exam findings is way down on that list. So is pulmonary function test. All right, so everybody kind of went, yeah, I don't know. And then 10 years later, during a quality improvement project, which CF loves to do, by the way, the foundation supports it and they love to do their quality improvement. But a couple of guys said, all right, let's do it this way. So they created a series of case studies. And they mailed them out to a whole bunch of CF centers, and they mailed them to the physicians, and they mailed them to the nurse practitioners, anybody seeing patients at that center. And they just modified little things, you know, like a real case, but, you know, here's what we have going on. Their FEV1 was this, it's dropped by this much. Was this an exacerbation? Interestingly, what they found was that within a single center, there were differences between physicians. Sometimes there were even differences in a single physician. So where he might call one an exacerbation, the next one he didn't. So you still see that we are dumbfounded by defining what an exacerbation is. What they found to be most likely to prompt the physician to want to treat this as an exacerbation were systemic symptoms. Again, physical examination is way down on the bottom. It blows me away, but there you go. Okay, so at our center, what do? So we are going to try to do oral antibiotics every time they roll in the door if we can. Now, obviously, if they're toxic, if they're hypoxic and they're not baseline hypoxic, if they're not going to take it, why prescribe it? That's kind of dumb. If they can't tolerate it, and I have some patients who simply can't tolerate oral antibiotics, they're going to start throwing up. It's just a fiasco. We've tried, it's a fiasco. Or if they're resistant, why would I treat you with something that you're not going to respond to? So those would be the only reasons that I wouldn't try to go that route first. But if they fail that, then obviously we're going to recommend admission. Or if they get worse in the process. Okay, and what we try, or at least attempt to do, is culture-directed therapy. So we look at the last culture, we try to use that as our starting place for where we would suggest IV antibiotics begin. If they've ever grown Pseudomonas, however, I'm probably going to want to treat Pseudomonas, because while I knew what they had 3 months ago, when they came in today, I have no clue. And one of the best examples that I saw just at the most recent national meeting was a single center, very small center, and they watched a single patient have a progressive decline in lung function over about 2 years. Every time they cultured, every time they treated what they saw, 2 years down the line, that patient was growing Cepacia. They didn't culture it, but maybe they should have been treating it. So if we see Pseudomonas, I know Pseudomonas is a bad player, I know it's going to cause decline in lung function, I'm going to target that one. And if they have staph, then of course we're going to treat that as well. So keep in mind that sometimes we're going to recommend things that may not make a lot of sense, because the CF clinic has only been at University Health since June of last year. Prior to that, we were located at the health unit, and all of our cultures were sent through Omega Diagnostics. So we may have in a black binder somewhere exactly what this patient grows, but it's not going to be accessible to anybody here because it's not in the Epic system. All you got to do is come to the office and we'll be glad to show you, but it's not going to be found in the computer. We recommend continuing their chronic therapies with the exception of inhaled antibiotics, and that should obviously make sense. I wouldn't want to compound toxicities when I'm already bombarding them. We always recommend an increase in whatever respiratory care they're doing. Most patients are doing 1 to 2 times a day bronchodilators, airway clearance. We want to step that up. That's part and parcel of what treatment for an exacerbation is going to include. And I can tell you, because I've had some very stubborn patients who have laid in a bed and refused airway clearance and just sucked up antibiotics, and at some point that stops working. If you don't get the mucus out, it doesn't matter what else you do. Obviously we're trying to feed them. Usually they come in with weight loss. We're pushing calories. And then early on, we're looking at their social situation to see, can we send them out? And we will even put that in our notes to you guys. Yeah, this is a candidate for home IV therapy, or And that's either because we've had a bad experience trying to send them home with home IVs and something that the patient did that was kind of scary, or they simply don't have the resources. We also recommend weekly monitoring their pulmonary functions. We're going to do this when they come in. We're going to do this at day 7. We're going to do this at day 14 so that we can show that what we have chosen is working. They get a culture at the beginning. If something comes up in that culture that's absolutely different than what we expected, then we need to change therapies. And we're totally on board with that. Okay. Now I want to say something about home IV therapy while I have all you guys here. So home IV therapy in CF patients can get really complicated. And we have specifically developed an order set, and we will be more than happy to work with you guys on this. It's very comprehensive. It covers absolutely everything this patient's going to need from the minute they walk out of the door to the minute they come back for follow-up. We've reached out to case management. We've talked to them about these order sets. But let me tell you, if these order sets aren't right, then the patient, one, doesn't have a timing schedule. We got 2 Q8s and a Q6 and we're sending them home. That's like saying, here's a newborn baby, you're gonna be up every couple of hours either setting a medicine out or hooking a medicine up or unhooking a medicine or flushing a line. Here you go. If we don't give them something to go with, here's your timing, here's when you need to be doing the medicines, they're lost. They're absolutely lost. I've seen patients go out without one of their medicines. So they got 2 of the 3 that they were supposed to go with, but oops, we forgot the 3rd one. This problem. They gotta have flushes. They may need drug levels, particularly if we get them out fast enough, we're gonna need to repeat that on the back end. And they've gotta have a follow-up so that I know 2 weeks was adequate. Maybe they need 3. Also guys, my last little thing. If it's not done right, y'all never know it, but I do. And I get to sit there and I get to listen to every single grumble about it as they grumble and grumble and grumble. And I didn't do it. And you residents know exactly what I'm saying when you have to sit there and smile and say, I'm sorry, and in your head you're thinking, but I didn't do it, right? Y'all all have been there. So please ask us if you don't know. Please ask us if you need help with it. It will save me lots of headache and heartache if you ask me. This is the form that we have created, and you can see it's very, very complex, but it has a start date. It has a stop date. It's got how many mLs of saline I want my drug mixed in. Why would I do that? Who cares, right? No, it's a big deal because we don't send them home with a pole and a pump. We send them home with little balls, these little infusomate balls that infuse over a certain time depending upon the volume that's in that ball. So it really matters how many mLs are there because it depends on how big the ball is. And that ball and that volume determine how quickly that drug's going to go in. So it does matter. If we don't let the home IV company know that they have a port, they're not going to get the right flushes. That matters because these guys will clot a line faster than you can blink. So that matters. If they need follow-up levels, that needs to be noted. And let me tell you, I've seen patients who've received drugs 50 times. And on the 51st time, on day 7, they have an allergic reaction. I walked into one day, patient's laying there, covers over her head, one arm sticking out. That one arm was covered completely in hives. Thought I was going to have a stroke. Down go the sheets, patient's head to toe hives. Luckily, she was still breathing. Life was good. We treated it. But that was probably the 51st time she had received that drug, and she was halfway through her therapy. So we have to send them home with an anaphylactic kit. You gotta. You never know when it's going to happen. So you can see on here how complex they are when everything is descriptive for not only the home IV company, but also the home health company. Please, if y'all need help, ask us. Okay. So I told you kind of how we do it. This is why we do what we do, the way we do it. So in 2009, they put out, how do we treat a pulmonary exacerbation? Again, they weren't attempting to define it because none of us really can with any consistency define it. But they did say how they think we should be treating the patients. And just so you know, we're doing it all right. But they looked at the site of care. So when I say that we're looking at their social situation and we're assessing on the front end, this is what we're assessing. Is what they can do at home the same as what they can get in the hospital? And if that answer is no, then there's no reason to send them home. A recent study at the national meeting showed that just home IV therapy without the hospitalization, home IV therapy is equivalent to orals. So if I'm going to send them home into a situation that's not the same, I might as well have just given them another oral antibiotic, because that's how likely they are to return to baseline. And by the way, that is the goal. That is our goal every single time. I don't want to lose not 1 percentage point in any of these patients because I may or may not ever get it back. said that is our goal. We're striving to keep their lung functions up. Benefits us too on the back end, but it benefits them for the rest of their life. So that's what we're working for. So what are we looking for at home? First of all, it's labor intensive. I just told you, it's like sending them home with a newborn baby. I've had parents go home with home IV schedules, some who were very creative, who made spreadsheets and they had red and yellow and blue and when and what. And they came back and said, don't ever do that to me again. It was horrible. I'm exhausted. Well, what if it's just the adult who's the single provider for the home, who's saying, I want to get home so I can go back to work? Really? And you're going to be up all night and you're going to be hooking up all day. And somewhere in there, you've got to find time to get the same equivalent airway clearance that you were getting in the hospital. You see why it usually doesn't work. And sometimes these patients have other comorbidities, particularly our diabetics. When we start throwing aminoglycosides plus vancomycin and they've already got diabetes, their kidneys are going to go whack. So sometimes we simply can't send them home because of the dangers of what these drugs are going to do to them. They looked at chronic therapies. Should they continue them? Should they not? And the recommendations you can see for yourself. Yeah, continue everything they're doing at home. Increase their airway clearance. What they really couldn't say what to do with with their inhaled antibiotics that they're taking on a regular basis. There is the potential for increased toxicity. There's really no good studies that have looked at, is the patient going to do better if we continue everything? So right now they're just not saying. We have chosen not to, simply for the toxicity standpoint. How many antibiotics do we use to treat Pseudomonas? That was one of the things they looked at. It would be so great if we could do a single drug, if we could do monotherapy. It would decrease toxicity. It would decrease potential allergic reactions down the road, which many of these patients do become allergic to different categories and classes of drugs. So it would be great. But there's just not enough data to say that one is just as good as two. So for now, they're saying stay with two. Dosing and duration. So one thing that we try to do is once daily dosing of aminoglycosides. I know y'all do that routinely. We try to do that in our CF patients. The problem comes in when they're little, their kidneys almost over metabolize. And so we almost can't push enough drug at them. We give them big doses and we have to dose frequently. As they age, their kidneys get tired. They get worn out. And so we can give them big dose and suddenly they're toxic. By the time that we work it back down, we're actually giving them 3-time-a-day dosing, but only giving it once a day because that's all their kidneys can handle. So they do encourage that. If we can, we do. We know, we've tried before. We know these patients really well. It cracks us up, by the way, when y'all say, by the way, I've got so-and-so in the ER. I'm not sure if you know them. Guys, we know them. We know them too well. We know their grandma. We know their cousin. And a lot of times I can tell you what their baseline FEV1 is. I can often tell you what they culture with nothing in front of me. We know them. You don't even have to say, do you know them? We know them. All of us know them. Too well. There has been, I'm diverging for a second, I'm gonna get back on track. There's been a push to do continuous infusion beta-lactams because we know that the longer we can keep that steady state, we're gonna get better kill. This is hard, guys. This is really hard to do continuous infusion in this population, particularly when you're trying to juggle 2 other antibiotics. And insurance cannot stand this. They want them out. They want them on home IVs. You can't do continuous infusion through home IVs. It's a disaster. We've looked at it. We've tried it in numerous ways. And I'm gonna be honest, I'm not seeing a whole lot of better outcome when we do try it. So for right now, we aren't doing it. We may revisit this 5 years from now, I don't know. But right now, they're saying there's not enough evidence to support it either. So there you go. Okay, and then I just brought this slide back in so that you can see everything that when they talk about what's optimal duration. Well, we got to go with anecdotal evidence. Where do we get anecdotal evidence? We get it from the registry. What does the registry say is the optimal duration? In other words, what's everybody else doing? This. This is what everybody else is doing, and for now, this is what we have to go with. So we treat for 14 days. Okay. And one last little thing I wanted to bring in, I know maybe I won't run over time, because it's new, are the latest infection and prevention and control guidelines that came out. These just were released in August of 2014. Huge controversy over all of this. In fact, a big chunk of the national meeting focused on this. The patients are not happy about this. And let me just tell you, they have gone from, when I started CF Care, camps for CF patients, time spent in the waiting room together, time spent in the hospital together, parties. We used to have parties at what's called the Hillman House, which is kind of like the Ronald McDonald House for pulmonary patients. I mean, they used to have Christmas parties and Santa, and they all piled up in Santa's lap together. To now we're saying only one CF patient is allowed to attend any CF-related event. We want a 6-foot rule between all CF patients. We don't want them cohorting. They can't share rooms. They cannot all pile up in the same bed and watch a movie. They've had some major changes in their life. Some of them are completely on board with it. They get it. They've seen what happens. They've seen transmission of organisms. Others absolutely hate this. And so there's been, and I mean, I get it. It's nice to know that somebody else has the same problems that I do and the same drugs and the same dilemmas, and yeah, that's great. But at what cost? And that's where we had to go with this. So, but I'm not going to talk about that patients and all that good job. I'm going to talk about what we are expected to do. So, the latest guidelines emphasize the need for contact and droplet precautions. Droplet really only where it pertains to CF transmission. The recommendation for all of us is good hand washing, gown and glove with every patient, regardless of culture status. So previously we were saying if they're cepacia, if they're atypical, we're going to gown and glove. But everybody else, Pseudomonas, MRSA, whatever, we don't have to. The new guidelines say yes you do. Because, for the very reason that I started off saying, I know what you had 3 months ago, but I don't know what you have today. And there's been numerous times that somebody's rolled into the hospital and we've cultured an atypical, and I went from that room to the next room. Yeah, I washed my hands, but I leaned on the rail, I leaned on the bed, I shared my stethoscope. Did I pass it on to the next person? Maybe I did. So now we are gown glove, every patient, regardless of culture, inpatient as well as outpatient. So this is happening across the board for them. Some of them are embracing it, they love it. Others are like, you make me feel weird, but they'll get used to it. The other thing we do in clinics, which we've been doing for years now, we immediately room them. They spend the minimal amount of time in the waiting room for processing, and oftentimes we're still pulling the patient in and leaving a family member to complete paperwork up front. But they're roomed as soon as they show. They're all given a mask as soon as they show, and they wear that mask anytime they're not in their clinic room. The guidelines requested that children 2 and younger have their own special clinic. So we have designated clinics. We have a baby clinic that's 2 and under. We have pediatric and toddler clinic. We have adolescent clinic. I hate that day. And we have adult clinics. So we have cohorted all of our patients into specific clinics. Patients don't go from care provider to care provider to care provider, but instead we all go gowned and gloved into them. The only time they leave their room is for triaging, vital signs, and for their pulmonary functions. Some centers don't even do that. Some centers even are rolling the PFT machine patient to patient to patient. In the hospital, single patient room, unless they live together. So if we've got a brother and a sister who are in the hospital at the same time, or a brother and a brother or whatever, then of course they can share a room. They do at home probably. But other than that, they say single patient room. And then just for the patients, we say 6-foot rule. They're a mask anytime they are outside of their clinic room, hospital room, anytime they're in a healthcare setting. So if they're seeing the rheumatologist, they should be wearing a mask. I bet they don't, but they should be. Anytime they see the endocrinologist, if they're sitting in a waiting room full of people, they should be wearing a mask. Good hand hygiene, respiratory hygiene. We have big posters. We have all kinds of education on this that's delivered to the families. You know, coughing into your elbow, not your hands, or a tissue if that's available. And then, of course, no cohorting. Okay. So a couple of things that I just wanted to mention. End-of-life care. This is not our strong suit as a center, and I'm going to be the first one to admit it. It's a very important part of CF care. We absolutely should be doing a better job with this. And we've had lots of talk and discussion as a team about end-of-life care. Where we have come with this is starting around an FEV1 of 40%. We are going to go in and introduce the concept of lung transplant to see what their wishes are. If they're not desiring transplant, we're trying to get our hand on those 5 wishes books so that we can take those in and have discussions. We've got designated team members who really like to deal with issues like this and to educate the families. So we're trying. And that's really going to be our latest push, is going to be end-of-life care, trying to tackle this and get it right. This is our other area that we fully recognize we need to work on, and I'm sure all of y'all are like, yeah, you do. And we're totally aware of this. But here's the thing. We have an adolescent clinic. That's when most centers start the transition process, but our patients don't go anywhere. We're not transitioning them from the pediatric world to somebody else. They're still coming to the same clinic. They're still seeing the same providers. There's no real transition, but instead they're simply transitioned into a different clinic that's now called adult clinic, and we expect more of them. Oh, okay. Well, that's not really going so great, and I'm sure you can all attest to, we have some 5-year-old, 32-year-olds. I get phone calls from 30-year-olds that their daughter or son is sick. But we are towing the line a little more. We're like, that's too bad. Can you please have them call us? Because they are 30. We are trying to push them, kicking and screaming and clawing, into the adult world so that they can act like an adult. But if I wait till they're 18 or they're 21, I've kind of missed the boat, right? So we're starting this transition with an education piece at all ages. So really, a 10-year-old should be able to tell me most of the medications that they're taking. They do it every day, right? I had a cerebral palsy patient who could list every one of her medications, exactly how many she took, exactly when she took them. I was astounded. How are you doing this? And her response was, why wouldn't I know? I take them every day. I thought, light bulb moment. So yeah, our 10-year-olds can do this. They should be able to do this, and we're encouraging them to do this. Now sometimes I get, oh, the pink pill? Is that what you're talking about? But okay, sometimes we get that in the adult world too. I'm just saying. So you can't fault them too hard. Or they may tell me, I take my allergy pill, but they can't tell me what it is. But that's okay, because it's a first step. So we are pushing and pushing and pushing to get our patients to transition a little bit better. The last thing I wanted to say is, please keep in mind that many of these patients have trust issues. And so sometimes you're going to get some looks, and sometimes they're going to say, well, does Dr. Jones know about this? Please keep in mind that they have been seeing me now for 15 years. And like I said, I know their grandma, okay? I know everything about them, and they know this, and that's their comfort level. Not that they are saying there's anything wrong with you or the way that you do things. but only this is who I know. This is who I get. So again, be a little empathetic to them. Okay, last thing, the CF Foundation is your best resource. If you come across something and you're like, I have no clue what this is, I have no clue what to do with this, it's probably on the CFF.org website. There's a page specifically for adult care with all kinds of handouts for patients and families. All sorts of information can be found on this. So any questions there? And one more little thing. I have 2 nurse practitioners that work with me. They round 5 days a week, every morning before clinic. They're a great resource. If you have a question, please talk to them. They're there. They've been in to see the patient too. They know what's going on. We're going to talk about it when I see them. I see them at least 3 days a week during the week, and then we, of course, do call on the weekends. But find them or find me if y'all have any questions. And last resort, every single Monday from 12:30 to about 1:30, you can find our entire team in one spot, guaranteed, talking about inpatients. So if you're having a problematic inpatient on Mondays, please come talk to us. We're on the 5th floor. It's 5232, I believe. It says pediatric pulmonary on the door. We will be in there specifically discussing inpatients. And if somebody from the team, a student, intern, resident, wants to come and talk about something they are struggling with, we'll be glad to talk to them, hear your side of what's going on, and see what we can do to fix it. We're open to communication. We all have cell phones. We all have beepers, and they're on us all the time. Sometimes I wish they weren't, but they are. I've been found in Seattle with a positive sweat test. If they can do that, y'all can find us, I promise you. So, okay, that's all I got. Any questions? Silence.